So I'm going to defend the virtue and honor of laser treatment that used to be our mainstay and that has come into disrepute and disrespect in recent years. We know already from Protocol T that most drug-treated eyes for DME all need laser treatment. So in a sense, I win. We still need laser. However, if laser treatment means photocoagulation, I give up. You win. No mas. Fortunately, laser doesn't mean photocoagulation. Why are we even having this debate? That's the interesting thing to me. It's our own fault. What if every oncologist in the world from the beginning of the specialty of oncology believed that the cure to cancer was causing vomiting and hair loss? That's kind of absurd. And if you understand that, now you understand the relationship of ophthalmology to photocoagulation. Let's look at laser a different way. What is photocoagulation? It's a severe, acute, disseminated, iatrogenic multifocal chorioretinitis. It's actually amazing it helps anything at all. And this is why drug trials choose to compare themselves to photocoagulation every time. They know they're going to win. Yet, incredibly, I'll suggest that laser still wins. In the same studies that Dr. Hamilton just quoted, it's important to realize that when patients have lower levels of diabetic macular edema and better levels of visual acuity, they do just as well with laser as with drugs. So there's really no advantage to drugs if the visual acuity is good, and most eyes still need treatment with the laser eventually. All the studies incorporating laser treatment have shown that at the end of the day, laser is actually more effective at reducing macular edema. Where it loses is on a visual acuity front. So why are the visual results with the laser treatment worse, with photocoagulation? This. So even with photocoagulation, though, if they present with good visual acuity and lower levels of macular edema, they don't need drugs. The ones that do need drugs still need laser, and if you treat early, you won't need drugs at all. This is not early, with due respect to the EDTRS, nor is this. When you see anatomic changes, this is advanced end-stage disease. And that's what we base our treatment decisions on. So why not treat earlier? Why not treat preventatively? Well, this and this. We don't want to do these things preventatively. So the problems with photocoagulation are many, and we know them very well. These are the risks of treatment with conventional photocoagulation. So how do we know drugs are better? Well, this is an interesting question. We can look at real-world evidence. Globally, there's almost $600 billion spent on advertising and influence a year, so it must work. Currently, pharma pays for over 90% of all randomized clinical trials in medicine and ophthalmology. They pay all the investigators, all their clinics, and they have now become the source of virtually all high-quality data that we tout so much as being important. I would submit that drug treatment to manage diabetic macular edema is simply a bad idea. We're treating a global epidemic of a lifelong chronic progressive disease with short-acting, expensive drugs that require experts to administer for years. It's a foolish strategy. So now what? If photocoagulation is bad and drugs are bad, what can we do? Well, we can still do retinal laser, but we can do modern retinal laser. So what is modern retinal laser? Well, it's not photocoagulation. It's low-intensity, high-density laser, of which I would submit SDM is the epitome. It's sublethal to the RPE, and it's effective in all reported applications, improving retinal and visual function. It's anti-inflammatory, and it's infinitely renewable. So before, when we tried to figure out how laser treatment worked, we were trying to figure out how damaging the retina helped things. It turns out that it doesn't, because you can do a better job without damaging the retina. And that led us to focus on heat shock protein activation. These are the risks of retinal photocoagulation on one side and the risk of SDM on the other side. That's an exhaustive list. Lasers lose to drugs in only one way, speed of action. Laser, however, sublethal laser, works physiologically, and thus it works perfectly, multivalently, and addresses the problem most effectively. So we have to get over our misconceptions, and SDM really proved photocoagulation to be false almost 20 years ago now, but it's still dying a slow death, and I can tell you in the United States, it's still a very common mode of treatment. So how does SDM work? Basically, we trick the retina, the retinal pigment epithelium, into thinking that we're trying to kill it. And by doing so, we activate heat shock proteins, which are not activated to respond to chronic disease. This initiates a reparative sequence and normalizes retinal function. Elicits an acute inflammatory reaction, and the absence of tissue damage reduces chronic inflammation and is immunomodulating. And this is a nice photomicrograph of in a study by David Kent and associates, where they performed SDM on one eye of a mouse and show bone marrow stem cells going to both eyes after treatment. So clinically, SDM behaves as a nonspecific trigger of disease-specific repair and acts like the reset button on your electronic device. What we try to do is we try to maximize this effect by doing confluent treatment throughout the retina. And this is a very simple schematic of how it works. Well, not so simple. So basically the cell's normal, we get sick or we get old, it gets sick, it starts misbehaving, and if we don't do anything, eventually it dies and we have the disease sequelae. What we do is we treat with SDM and interrupt that cycle. We normalize cell function. We continue to get old or continue to have diabetes and things go bad again, and so we need to retreat. But in so doing, we stop progression and we can even reverse disease progression. So we turn back the clock on chronic progressive retinal disease. Now, some people think that diabetic retinopathy is one disease on one side of the arcades and a millimeter on the other side, it's a different disease and we treat them differently. I don't. I think it's all one disease. So I treat diabetic retinopathy in just two ways. One is pan-macular treatment, where the entire back of the eye is treated, and then pan-retinal, where everything outside of that is treated. Essentially, we treat the whole retina because it's called diabetic retinopathy. So these are the pictures of diabetic macular edema before and after treatment. Hopefully you can tell the ones that are looking better. This is an eye with PVR and PDR under silicone oil that was treated with resolution of macular edema. For drug non-response, you can use a laser and combination therapy to reduce the number of injections. This is an eye that had many treatments and eventually responded only to transfoveal SDM. And here's the progression of an eye after a single treatment over a period of a few months, showing resolution of macular edema. Another one, another one. These are eyes that all had a vision of 20/25 or better prior to treatment and were improved by transfoveal SDM. A good study to look at is Levinsky, Cardio, and Mello's study a while back. They did a 3-arm randomized clinical trial where they showed that the SDM strategy worked far better than modified EDTRS or lower density grid. If we compare SDM from that study to the Protocol T aflibercept arm, we find very little difference. The end result was essentially the same, except for the cost. The cost of 2-year treatment of eyes with aflibercept versus SDM is about 20 times higher. So let's look at diabetic retinopathy. Here are eyes with severe non-proliferative retinopathy before and after a single treatment of SDM. Another after a single treatment of SDM, not after monthly injections for several years. Another after a single treatment of SDM, and another, and another. What about PDR? Many people think, well, you can treat diabetic macular edema with Micropulse or a subthreshold laser, except that PDR is a different disease. It needs different treatment. It's interesting that drugs work equally well for PDR and macular edema, but for some reason we think that lasers need to be handled differently for the. So here's an eye with NVE, and here's the same eye 9 years later without progression of the NVE. Notice also the lack of fibrosis. Here's an eye before and after a single treatment of SDM. Another one, more, 3 years after a single treatment. Here's an eye 15 years after a single treatment of SDM. This eye had florid retinal neovascularization, disc neovascularization. You can see it's regressed, and that little fibrosis. So I submit that it should be your first choice. Why? It's safe, painless, there are no known risks, highly effective, infinitely repeatable. You can combine or replace with drugs, and it's the only preventative option. We know that early treatment is the most effective and that patients prefer laser over injections. It's less expensive, less intensive, and I would submit it's more effective because we can treat earlier and prevent visual loss. This is the current model. This, I think, is a better model, and with a sub-threshold laser treatment, we can treat preventively and do this. So here's the problem. We can't get studies done on laser treatment. So I actually asked Novartis, would you sponsor a trial? No. Regeneron, would you sponsor a trial? No. And then I asked the third musketeer, the DRCN, and they said no. So do I have any evidence to support what I'm saying? Well, this shows the injection use for DME in the United States of about 220 retina specialists. The average use of those 220 retina specialists is the high line above, and that's me on the bottom. I use virtually no injections for managing diabetic retinopathy. Despite that, and this covers 82,000 eyes, despite that much lower use of anti-VEGF, my visual results are actually better than the larger group. So I would submit that I win. Use modern laser. Treat early. If you do, you won't need drugs, and patients will not lose their vision. Drugs are wonderful, but it's even better not to need them. Laser should be your first choice for treating DME and DR and PDR. Thank you.